So the topic given to me was to add IO to chemotherapy or not. But with the permission of the chair, I modified it a little to include chemotherapy, targeted therapy, as well as IO, because I think the debate is not settled as far as we had seen, earlier. So this is what we'll try and cover over the next 40 minutes or so. We will focus on gallbladder because it is our problem in India. We will focus on the Indian scenario, and I don't think there's much more to be said on immuno because it's been covered extensively by Professor Chan as well as the debaters, but let's try and get some nuances out. So this is the first case all of you can go through. It's a 56-year-old male who presented with obstructive jaundice. His hemogram was largely acceptable. He had a bili of 9. A CT showed a GB mass with the unequivocal metastases, and a gram was done for the jaundice, and it was a type 4 block. So he underwent drainage, and at the same time a cytology was done, and that showed adenocarcinoma. Post drainage, his LFTs settled largely to acceptable limits, and post drainage he had a good ECOG PS, and he was all set for us to start treatment. So I'll start with Dr. Amol Patel, and I'll take probably 2 opinions on all these questions. So Dr. Amol, are you there?
I'm there.
Yes, Dr. Amol. So quickly, the 4 questions that you have on screen. Is there a certain level of LFTs that you wait for before starting treatment? Would you consider a biopsy? And what proportion of your patients are PS0 to 1 as opposed to PS2? And do you use systemic therapy in patients with PS2?
So the first question, up to even 15 bilirubin, I don't wait for further settling down. It is a very aggressive malignancy. If you don't treat, the patient die in just 8 to 10 weeks. And already we have spent a lot of time in establishing the diagnosis. Problem is real. So I don't wait. In such situation, I just start with gemcitabine, and PS is good, then I add cisplatin too, obviously with the modified doses. Then in the current scenario, yes, majority of my patients, they go for certain kind of a trial, so biopsy is must in them. So we convince them, we do biopsy. 10 to 20% of the patients, they have this PS01. 0 is absolutely PS0, there no much actually, frankly speaking, no one, unless somebody has detected post-cholecystectomy. And last question, certainly PS2, they are the majority, PS3, they are the majority of our almost 60 to 70%, we treat them.
Okay. I think you covered all that in a short span of time. Great. Dr. Atul Sharma, is sir there?
Hi, good evening.
Good evening, sir. So I'd like to have your take. Most of the things which Dr. Amol said, even I kind of agree. But is there a certain level of LFTs that you wait for? He said he doesn't wait. Is there anything that you would wait for, or would you just start?
So I think in our personal practice, we used to wait until the bilirubin is up to 3 or less than 3. So over a period of time, we have moved little forward, and probably now I consider it's a kind of arbitrary limit. I don't think there's any justification for yes or no. For up to 4, we will be comfortable in starting on chemotherapy. That is number 1. So usually, and most of the time, we usually do not wait for the liver, not bother much about the liver enzymes and this thing. It's the bilirubin which we are more with them. Number 2, with regard to this thing, the second question is regarding the biopsy. We have a tissue diagnosis. I probably will not, unless patients wants to have the means and expenses for either the other biomarker, which probably can be biomarker driven therapy, which we plan to, or some research purpose. That is number 2. Having said that, now more and more evidence are coming up that probably either you have the tissue repository, and it's always better to have a biopsy. You can do from, in this particular case, I understand you can do from the omentum also, this thing. Third question regarding the ECOG 01 and ECOG 2, I think probably I would say only about 15-20% of the patient will present with ECOG 0 or 1. More than 50% will be about probably around 40-50% will be 2, and 1/3 of the patient will present with the ECOG 3 or ECOG 4. So the last question of yours is, you start chemotherapy for the ECOG 2? Definitely yes, because that is the majority of the patients. And so I personally prefer gemcitabine. The short answer is gemcitabine and platinum. If you want to be specific, I prefer gemcitabine and oxaliplatin based on our own data. I have shown more than once that this is the thing. Having said that, I will encourage the patients to participate into the clinical trial. And right now we have just written and probably will starting for the FOLFIRINOX compared to gem platinum M-FOLFIRINOX.
Great. Thank you, sir. I think so. What we could understand from these answers is from two very senior people here is that one, more and more people are doing a biopsy. Two, ECOG PS01 is rare. 0, I don't see. 2 is, a subgroup of patients that we see and probably treat. So those were the two learning points for us. Great. So for discussion's sake, a biopsy was done and it showed a moderately differentiated adeno-CA. So I'll start with Dr. Chan. Would you consider any biomarkers in this patient of gallbladder cancer? Professor Chan, please.
I think this depends on the different regions and the reimbursement criteria. I think in America or in those places where the NGS is reimbursable, I think it's now a relatively a standard now that we send the tissue for NGS and also send for the MMR, IHC or MSI PCR, depends on which method you prefer. And also we also send for HER2 FISH because sometimes NGS may miss some of the HER2 amplification in my experience. And PD-L1, yeah, usually we send together, although I think PD-L1 is not as informative. Of course, you see very high PD-L1. I think we are more inclined to give PD-1, but negative, it still doesn't exclude. So I think all these we will send routinely if cost is not an issue. I'm not sure about the situation in India. For example, in Hong Kong, sometimes some of my patients could not afford. It's still not reimbursable. Then we send some selected cheaper tests like the HER2 or PD-L1, hopefully to give some guidance for the treatment.
Fair enough. From going to Dr. Bharat, I know that in the South, gallbladders is a little less common, but given the scenario, what biomarkers would you consider in your setup?
In a metastatic disease, as of now, I would prefer an NGS to look for, any actionable mutations. For any patient who can afford, the test and probably the subsequent therapy. PD-L1, yes or no, sometimes yes, but more on the target, looking for a target. If nothing is possible, then at least HER2 alone is something that I would look for because we have the drug. Although we can talk about NTRK fusions, we don't have the drug easily available in India, and it may not be affordable also. So it is an issue, So, but HER2 is something that's available. So I think that we should definitely look for.
I'll take
Same
one more.
goes for FGFR. We don't have the drug.
Sure, I agree with you. I'll take one more on that. Is Shekhar Patil sir there?
Yeah.
Yes, sir. So what would you do, sir? What are the biomarkers that you consider?
At least I will do an MSI and HER2 in all my patients who are having, because those are the two areas where we have got some treatment available. But if I have got a patient who is affordable, I will do an NGS because NTRK nowadays, we are seeing some patients NTRK positivity and we are able to get the drug on a compassionate ground also. So I think there are some patients who would like to have all the option. I had a recently patient of IDH1 mutation, and when I discussed with the patient, they told that it cost 10 lakhs. He was ready to get the medicine. He got it and started. So we cannot just leave it like that. We have to have an open mind, and at least MSI and HER2, I will do it in all the patients. And The rest all I'll do it depending on the patient's affordability and his interest in further treatment, sir.
Okay. So after those three opinions, the sense I'm getting is that HER2 and MSI, yes, if affordable, and NGS for all patients, if affordable. PDL1 is iffy. That's the sense I kind of got from the three answers. Great. So, it's the Indian scenario, limited biomarkers were done and the patient turned out to be HER2 3+, and not deficient MMR, proficient MMR. So, along with systemic therapy, would you use the HER2 positivity in your treatment paradigm initially? And I'll take an opinion from Dr. Shefali. It's HER2 positive, gallbladder. Would you use HER2 directed therapy?
Yeah, of course. I mean, I have a couple of patients in whom I got that opportunity to use anti-HER2 therapy, that is trastuzumab, along with the first line, and they did reasonably well. So I'm pretty more convinced that since we know that biliary tract tumor, we do not have much to do if we do not have a target actually. So I'm very much convinced to utilize this biomarker. Yeah.
Okay. Going to Akhil, he is at Varanasi where they see huge numbers of gallbladder cancers. Would you use HER2 directed therapy, and why?
Yes, sir. So, sir, presently we are running a joint trial, which is a multi-central trial along with your center. So, all HER2 positive patients will be enrolled in the trial where they will get trastuzumab. So, presently we don't have data about the benefit which is there from the trastuzumab in these patients, but it is very clear that HER2 positive patients have aggressive biology. This is very, very clear, and what we can see in these patients also. Previously also, when the trial was not available, we were seeing patients who were HER2 positive and not able to receive trastuzumab, they were having very fast progression. So definitely, if a biomarker, well-established biomarker is available, it is always preferable to use the targeted treatment, and we know the tolerance is good along with the chemotherapy.
Great. Yeah, so I mean, even though we are running the trial in HER2 positive and we'll probably complete accrual later this year, I agree that probably they're poor prognosis, and there's some data to say that HER3 co-expression portends an even further unfavorable prognosis. That said, there is actually no first-line data. There is absolutely no first-line data for adding trastuzumab or any anti-HER2 therapy to chemotherapy. This is some of the data that I could pull up, and for HER2, our own trial of trastuzumab plus chemo will complete the end of this year, so we should be able to present it next year. But all the data is only in second line. So with that caveat, I'd like to ask Dr. Amol here, because he's published some work on HER2 positive. What do you do, sir? Dr. Amol?
Dr. Anant, if Dr. Amol completes, then I would like to ask one question regarding that thing. That is what my practical experience on HER2 is also there. So in second line, probably it does not work. And that is true with the progression on trastuzumab plus chemo also. None of my patients did fairly well once they progressed beyond first line with trastuzumab and chemo. Okay. So I don't know what is the reason. So is the HER2 expression loss sometimes causing that issue, or it is something else which is troubling? But that is true, I think, on that scenario.
Sure. Point well taken. But Dr. Amol, would you like to add something?
Yeah, so with my study, which is a prospective study, and it was a huge, I would say, in terms of germline, or basically genetic testing, it was foundation in 50 patients. So there are very interesting points I would like to tell you here is HER2 positivity in females beyond 55, 60 years. What are the patients I have? They have a very unique disease, no jaundice, there is peritoneal seeding in all three cases. And in fact, the diagnosis was made after the laparotomy, the laparoscopic biopsy, and in that HER2 came positive. In two of the patients, they did well, I would say 18 months, but I had the opportunity to look for the mechanisms of resistance. So out of these two patients, they had concurrent HER2 mutations. And I was, as a mandatory protocol in my study, the trastuzumab only allowed in second line. So with the initial, what are the regimen we have, whether it is paclitaxel or the gemcitabine or paclitaxel or capox, whatever. But the trastuzumab, for just 2 months, again, the patients started having the CA99 elevation in just 6 to 8 weeks or 10 weeks time. And then with the background of the similar mutations which are there in the breast cancer also, and there are reports of lapatinib working. So I used to add lapatinib with nab-paclitaxel plus trastuzumab. And in those patients, they did fairly well. So there is a lot of issues here in gallbladder. If you see the report, it's not just HER2. HER2 is always with the something is there, whether it is HER2 mutation or there is HER3 amplification. In fact, there were patients who had only HER3 mutation along with it, and along with the HER2 new amplification and HER3 mutation, and there was some data from Japan that the HER3 mutation patient, they do well. So this kind of a complex situation are there. So it is not just one, umbrella which is going to cover it. It is, we need to know when we are studying the HER2 new. I absolutely agree with you, Anant. It is a very, very aggressive disease. In fact, one of the patient here, again from the Varanasi, we just did the biopsy, HER2 new came. He just asked me, we just want to go home. And the stenting was done. We will come after 2 weeks. He didn't come, came back to the hospital. When I called back after 4 weeks, bhai kya hua nahi aaye? Bale sir, wo to achanak bimari badne lagi aur idhar hi admit kiya and whatever, patient died. So there are multiple things in this. One point, I will come to PDL1 experience with this also. But certainly I advise you, Anand, because we need to see more of the tumor environment, other mechanisms of resistance, and then we would be better able to do justice for her to target in this situation.
Point taken, sir. Point taken. I think it's an aggressive subset, and we are all clutching at straws here, basically, and they do progress very fast. I'll just take Dr. Chan's opinion on this. How often do you use HER2-directed therapy in your patients upfront? Do you consider it?
Yeah, yes, if I really see evidence of HER2 amplifications, I do use it because I do think, say, I used to see it in gallbladder cancer, and because the prognosis is known to not very good, although the data are robust, data are lacking, but I still use it because of poor prognosis. I mean, my experience is quite good. We don't see additional toxicity too much, and my patients usually have more durable responses. But I do have one minor comment on this case, but maybe you can educate me on this. I'm actually a bit surprised to see there are two phenotypes. One is HER2 3+, and also
that was a mistake. It is a proficient MMR. That's a mistake.
Oh, okay.
Yeah.
That's okay, because it's very rare to have two phenotypes. So if I saw that, I will definitely double check. But okay, that's a typo. Thank you.
That's a typo. Yeah. So I think Dr. Amol's points are well taken, and we all would want to use anti-HER2 therapy, even if the evidence is a little iffy on that. So just to twist the case around a little, the same patient, actually had, again, a proficient MMR status and HER2 1+. They are not affordable for durvalumab, as is common in our country. However, ECOG PS is 1, and he's willing for all chemotherapeutic options. So I'll go to Atul sir and ask him, what would your treatment of choice be and why? Atul Sharma sir.
Just give me a minute. I need to read it.
So I just twisted the situation around, sir, saying that the HER2 is negative and it is MSI stable, not deficient as in the slide, and durvalumab is not feasible, but otherwise all set for treatment. What would you do and why?
All right. So basically, based on this data, that's option. Of course, if affordability is not an issue, you said this is deficient MMR status.
No, sir, proficient. That's a typo, sir.
Oh, this is typo. Okay.
Yes,
sorry.
yes.
All right. Then the options will be either in a clinical trial using the modified FOLFIRINOX based, I think, comparative study, or gemcitabine oxaliplatin.
Okay. Okay, right, sir. Dr. Bharat, what would your options be? The patient is PS1, willing for treatment, not feasible for durvalumab.
Most likely option 1, and in some highly selected patients, option 3. Gemcisplatin or gemcisplatin nab-paclitaxel, but that's only after a lot of discussion in some selected patients.
Okay. I think, I mean, we do agree that while Gemcis has been the standard for the last decade, I think GEMOX is there's a phase 3 trial from India. Atul Sharma sir was the PI, where they showed near equivalence. And I think this was alluded to earlier by Professor Chan as well. The Gemcis nab-pacli, the survival data is quite nice. The survival is around 19 months with almost doubling of response rates. So in a patient with PS1, if not in a trial, I think an option that's up and coming is Gemcis nab-pacli. I agree with that.
Dr. Anant,
Can I ask a question?
Yes, sir.
Because you are, sorry.
We have a lot of the Indian colleagues sitting here and this thing. Just wanted to learn basically in their experience. Many of us are using chemotherapy, gem, platinum compound and this thing. What is the median survival they are getting? Because many of the Western studies, unfortunately, I haven't been able to breach this thing, wall of this thing, 1 year survival in any of our study.
So I'll do a quick head count. So we'll start from Shefali. What do you think is the median survival you see on an average? As Sir said, what would you say?
Yeah, so on an average, 1.5 to 2 years, what we generally encounter. So I take into account with the good performance status. So good performance status up to ECOG 1, 2 I take, okay, because 2 generally respond once we do the biliary drainage. So I take it into account.
Shekhar Patel, sir?
Where does Shefali works? 1 to 2 year.
1 to 2 year median OS, including all things, sir. So
just sorry, don't worry my question.
Max Saket. Yeah.
Oh, okay, Max Saket. Okay.
Okay. Akhil, what your thoughts?
Yes, sir, we have done a formal analysis. It was intention to treat analysis, including all the patients, and our median OS is 7 months.
Absolutely. And can I say here, Anant, I am breaking in. I am breaking.
Okay, I'll just put that into perspective. We had someone say 7 months, and if I jump into the fray, I would say something of the similar sort, 7 to 9 months. We have someone who says 1.5 to 2 years. That's a wide range. I'll take one more opinion, Dr. Bharat.
I would say around 12 to 14 months. Okay. But remember, Anant, the sort of patients you see and the sort and the number of patients we see in private setting is hugely different, both financial wise and nutrition wise, especially nutrition wise.
I completely agree. That is why I say median 1.5. So, because the poor PS nutrition wise is very less likely that we encounter. They are more of a better profile. Nutrition does play a role actually.
Atul sir, does that
maybe?
I'll just take half a minute and add to that. Even in our FOLFIRINOX study, modified FOLFIRINOX, where which was limited to only ECOG 0 and 1, we were not able to breach 1 year survival.
Yes.
And they all got this thing, prophylactic GCSF. There were no mortality. Most of them completed planned treatment, but still the survival was, I think, probably 310 or 15 days. So it was less than, I think, just 10.5 months or something around.
So can I add something here?
Dr. Sahu was saying basically because of the predominant population of the biliary tract, so the cholangiocarcinoma, which biologically is a different disease than gallbladder cancer, that we need to keep in mind.
So a couple of points to add here. One, I think the cholangiocarcinoma point by Atul sir is well made. We had recently published our outcomes on cholangio, and there the survivals crossed a year. It was around 12 to 13 months. But gallbladder, if a patient of mine crosses a year, I'm kind of happy. It's not the norm. It's not the norm is what I think. But yes, we do have exceptions, and nutrition and economy do play a major role. That point is well taken. So for the purposes of discussion, this patient received 8 cycles of Gemcis. He had good response after 4, and at 8 as well, he has a maintained response. He has good quality of life now. He's PS1, no debilitating neuropathy or other symptoms. What will you do next? And I'll start here with Amol Patel, sir. Dr. Amol, what would you do?
Sorry, I just missed.
Sure. So the patient received 8 cycles of GemCis. He had response at 4, maintained response at 8. He has good quality of life now. His PS is 1, no neuropathy. He's asking you, what do I do next?
He is maintaining the.
Yes, he has maintained response. Yes.
Just observation to give maintenance.
Sorry?
I observe.
Okay, great.
Option 1.
Okay, great. I'll take one more opinion on that. Shekhar Patil, sir, what would you do?
Hello.
Yes, sir.
You are able to hear, sir? Yes. Hello.
Yes, sir, you're audible.
Yeah. I also will keep under observation and see it. Whenever there is a progression, I'll think about the second lines.
Okay. Professor Chan, what do you do in your practice of trial?
Depends on I think every option is feasible, depends on the age of the patient and performance status. For some elderly, I think usually they suffer a lot during the chemo. And I think it's very fair to observe and give them some break from follow-up and the treatment. But for some really young patients with good organ function, I do give sometimes a maintenance treatment like capecitabine to them, hopefully to improve the progression-free survival. The last point I would like to mention, this is not a standard. Actually, after the ASCO GI TOPAZ 1 data, there's some thought that maybe the divided survival benefit after the median OS, after 6 months, probably is contributed by the maintenance use of durvalumab. So there's some thought that we may skip the use of durvalumab in the first 6 months and then use it as a maintenance. Of course, this is not validated in the trial, it's not studied, but there's some discussion that maybe the durvalumab may be one of the choice of maintenance treatment, but we need high-level evidence to prove that. Okay. But this is a hot topic, and we need further data. Yeah.
Akhil, I'll take your opinion because you see so many of them. What do you do?
Sir, yes. As again, we share the same platform. We are doing a randomized trial where we are enrolling patients in a maintenance study, bevacizumab varlotinib maintenance versus observation.
Okay. So this is some of the data I could
enroll every patient.
Yeah. This is some of the data I could pull up. One is from our institute at Tata, where this is all retrospective data, and as Professor Chan said, it is a good topic for a trial, but there is no prospective evidence. This one was 396 patients. There was some benefit in OS. Later data from Seoul, South Korea said there is no benefit in OS. So I think it's a heads or tails, answer. And I think it is based on an individual clinician and physician decision rather than any hard data. This is the trial that Dr. Akhil had referred to. After 6 months of chemo, we are randomizing to observation versus bevacizumab and erlotinib, a non-chemo maintenance. We should be completing accrual at the end of the year. And it looks encouraging is, the least I could say. Great. So I'll now shift to cholangio because there are many targets available. This is a 49-year-old lady with hypothyroidism who presented with weight loss, anorexia, and abdominal discomfort. Her entire workup was done. She had liver-predominant disease, but with metastatic nodal sites as well. It's essentially an IHCC. So again, back to my older question, the biomarkers here. Dr. Atul, what would you do in these patients, assuming that they are feasible for all treatment options? Is Atul sir there?
Yeah, I am there. The questions beyond. So,
yes,
can you go back to the history?
So it's a 49-year-old lady.
Yeah.
Yeah.
So now move to this thing, and this is a cholangio.
Yes, sir.
So move to the next slide.
Yes, sir.
So are you saying that biomarkers have been done? No biomarkers beyond MSI?
So I'm asking you what you will do, sir.
So of course, I'll do the whatever is possible, go for the NGS and probably do whatever the available or this thing, depending, because we have a lot of this things, some data, number of agents for the cholangio available.
Okay.
Target driven or biomarker driven agents are available. So we'll go for the NGS basically. Of
Great,
course,
sir.
IDH and GFR2.
Okay. Dr. Amol, what would you do in your practice in a patient with intrahepatic cholangio with all options feasible, no financial constraints?
Obviously, I would do everything.
Okay. So when you say everything, how strong do you think is the evidence to do things like a TMB and PDL1? Dr. Amol? Okay. Okay. I'll go to the this one. So I agree that we would try and do an NGS. This is a paper published 2 years back, where in IHCCs you have, the IDH1 and the FGFR2 fusions. With regard to biomarkers for immunotherapy, I think this was extensively discussed. Dr. Atul, any thoughts on biomarkers for immune checkpoint inhibitors? I mean, these are some which I could pull out, but would you go with any of those biomarkers to predict a response, or would you just say, let's start chemo plus immune?
So we will definitely be going for the biomarker based at basically to select the agent other than the chemotherapy. And in case available and the means are available, it is showing, then of course I don't mind going for immunotherapy. So basically the simple answer is that of course this is the one disease or scenario where the biomarker should be done basically for immune checkpoint inhibitors.
Okay. But sir, how convinced are you on the prognostic or predictive value of anything other than MSI in biliary tract tumors? That is my question. MSI, yes, I mean, that is an easy one.
Yes, basically whatever the data we are coming at this thing, basically through the NGS at this thing, there's no question about MSI. But regarding the PDL1, so I probably personally think that the PDL1 probably is the one which probably, even because the gallbladder cancer as such is there is the dismal prognosis. Nothing beyond this thing, chemotherapy has been showing other than the durvalumab and this thing. So given the chance, even though this thing, whatever you have shown the predict possibly response to and this thing for unfavorable prognosis for the PDL1, I do not hesitate to go for the PDL1. And in case it is probably high, then probably these are some scenario where I probably, if the patient is affording economic, not a problem, will go for immune-based. I use basically.
Okay. Dr. Bharat, your thoughts on TMB? So Dr. Atul has told me, okay, PDL1, he may not consider, but he will do it. Your thoughts on TMB in biliary tract? Because TMB is slowly making its way into guidelines. Now, gastric cancers, they're saying can consider TMB. Some other tumors, they are saying consider TMB. In biliary tract, do you think TMB will guide you, not guide you?
See, we can do the test, Anant. That is, it's not a question of doing the test. We can do the test for patients who are going to be able to afford taking an immunotherapy. You can do the test. But even if you look at the keynote, which looked at all the TMB, the best responses were less than 60%. It's not as if, you have one biomarker and you can definitely predict a response. But if you're going to do the drug, it's always good to, as Dr. Atul said, look at the PDL1, look at the TMB, look at the MSI. At least you have some sort of a clue on whether this patient is going to respond or not. But if the patient is never going to take up immunotherapy, then I would not, ask for these tests. So that I think it's what the patient really affords. But if they can afford, I will look at all this, at least to my mind, to be predictive to a certain extent.
Okay. Yeah, I agree with you. I mean, if a patient can take durvalumab, then I would do the testing. It would help me explain whether he might or might not benefit, given the caveats that I think Professor Atul and you had mentioned. Yeah, but I would not consider it mandatory or not push for it. That's
absolutely right. Not.
Yeah. I think this is the study, I think has been discussed ad nauseum over the last 40 minutes. Everyone has pinpointed the flaws and the highlights. To me, I think one surprising thing was that in the study, MSI high, the data was missing in more than 50% of patients. I am a little surprised at that. I don't know why that happened. And to me, in this study, majority of the benefits were seen with maintenance. I think, as Dr. Sahu said, largely the curves are similar for 4 to 6 months, and then the maintenance probably kicks in. Professor Chan, any thoughts on that?
I think all of you have very nicely summarized and discussed the data, and I don't know. I think one of the reasons why the MSI phenotype is not available is because for the extrahepatic, usually it's quite difficult to obtain adequate tissues or cytology. I think this is a common problem in extrahepatic tissue tumor. But I think even you have MSI data, my experience is MSI phenotype is not common, very common in cholangiocarcinoma in general. My experience is probably lower than 4% overall. And so I think we certainly need more other biomarkers other than the known biomarkers like what have been discussed, PD-L1, TMB. I think in the future, this will be a very hot topic. Maybe liquid biopsy or some other like inflammatory gene signature. I think this probably will contribute more and to the overall picture.
Yeah, I agree. The only thing is that, I worry a little bit about the lack of benefit in gallbladder cancers because that's the disease we see. But then, as you said, this is all hypothesis generating. The study is not powered for these analyses. So yeah, that's something. So this patient actually received Gemcis durvalumab, then did well for approximately 9 months, after which there was unequivocal progression. She still had ECOG PS1 and adequate organ function. So my question is, Atul sir, what proportion of your patients are fit for second-line therapy?
I would say around 15-20%.
Okay, sir.
If you include the ECOG2 also.
Yes, sir. For sure, I'll include ECOG2. Dr. Shefali?
Yeah, so 30% approximately would go for a second-line chemotherapy.
Okay. Shekhar Patil, sir, how many of your patients go for second line?
Around 25 to 30%.
Great. And assuming all the biomarkers are negative, Shekhar sir, what would you choose? IDH1 is not mutated, FGFR fusion's not seen, proficient MMR.
Generally, we prefer to go for PFU-based treatment, FOLFOX or FOLFIRI or single agent capecitabine, one of the three things.
Okay, sir. Akhil, what do you do in your practice? Is Akhil there? I think Akhil is not there. Okay. Dr. Bharat, what do you use as second line treatment?
Most likely FOLFOX. If FOLFOX is not feasible due to technical reason, CAPOX.
Okay. Why the doublet?
See, only 30% of patients actually reach, 25 or 30% of patients are actually reaching second line therapy. And these are patients who are in good shape, good pace. Only then you're considering. At that point of time, these are the patients who would do well and live longer if you treat them aggressively. The rest of the 70, 75 are never going to reach that point. So if they reach that point, definitely a doublet is what I would go. Usually, because I would have used gemcitabine cisplatin in the first line, either FOLFOX or CAPOX in the second line.
Atul sir, I'll take one more on this. Atul sir, what do you do in patients who are fit for second line?
I think I'll go for GB Select.
Yeah, so I mean that's just to we did this trial in India.
Single agent iron.
Yeah, Dr. Amol, what would you do? Yeah, I mean we did this trial in India. We had predominantly GBC patients, and we didn't see a benefit with the doublet. So Dr. Amol, your voice is getting cut. Sorry. So, I mean, just to carry on that point, I mean, it's not, this was done in AIMS and TMH, and we didn't see a benefit with the doublet. Even if you do use the doublet, the difference in survival compared to active symptom control is a month in ABC6. So my point is that in advanced cancers, we normally go from 1 drug to 2 drug to 3 drug. So, I would be conservative in treating these patients, but outcomes are not great. I think that is something that we all realize. The biomarkers, yes, IDH1 and FGFR2. Any Indian experience with using FGFR2 inhibitors? Anyone? I've not used it. Anyone has any experience? Dr.
So,
Dr.
Dr. Anant, I think in intrahepatic cholangios, there is a trial going on with Dr. Nirmal Raut in Mumbai. So one of my patients got enrolled who had FGFR2 fusion in intrahepatic cholangio, who had a stable disease post-6 cycle GEMSIS followed by radiation. So still non-metastatic after that. But it was undissectable disease, so she got enrolled. So I think that trial is going on, and quite a couple of patients are. But that trial is for adafitinib. That is not for pamigatinib.
Yeah. Professor Chan, your experience with using any of these drugs, because they're not available on a large scale in India as yet.
Fortunately, I have experience, especially I have used 2 patients ivosidenib, and I've one patient I think few in the clinical trial saying futibatinib, and I have one patient pamigatinib. So far, the experience is the toxicity wise is very well tolerated. Of course, they do have some specific toxicity like the HFR2. We do see a phosphate issue. We need to give a phosphate binder, but usually the patient tolerated the drug very well. We don't see any big problem. Ivosidenib is also very well tolerated with some only marrow or fatigue. But the problem of these TKI is not surprisingly, you do see benefit, but or prolonged SD. But what you do expect one day, if as a monotherapy, after like 6 months, 7 months, they will have PD again, resistant clone. I think this is a general problem. So I agree with what has been discussed. Probably we need combination to prolong this PFS. Otherwise, it won't change the whole picture, even you found this biomarker.
Yeah, I think at least in intrahepatic cholangiocarcinomas, there is worldwide data, and I think the FGFR, there are now, I think, 6, which are 3 are approved, 3 are on the way. And in gallbladder, at least in Indian setup, we are a little excited about her too. I think that's something that we are looking at. And
Dr. Anant, can I ask one more question, please?
Please do.
So, I was really looking into if we see the GEMSIS data versus GEM alone, 11.7 months reported, median OS. And then 30% of the patients if reach the second line, and the worst OS in the trial you showed was 6 months, approximately, median OS. So why are we surprised to have that median OS total in, that biliary tract patients not to be 1.5 years? I was really keen to understand that what is actually making the difference, and we were surprised enough to have that idea. So 30% patients reaching second line and worst OS, you see the graph which you are showing, the table. So that is why I was surprised to understand actually.
Okay. I think so. One is that as we treat these cancers and others can chip in, it is not one disease. I
agree.
We're all clear that, the GBCs respond better, but survive less. The cholangios probably respond lesser, but survive more. And then nutrition, ECOG and all that comes into play. And I think if you do an analysis now in Indian patients, compared to the 8-9 months, maybe survivals are a little better. But 1.5, 2 years to me, I would be very
not
happy.
Exactly 2 years, 2 years in couple of patients, but on an average, yes, of course, I would not mind accepting that it would be, median OS of 1.5, not 7 months to,
So, yeah.
it is something difficult to accept for me.
Those are the patients that, push us to treat these patients more. I agree. So with that, I think, we reached the end of our 45 minutes. I would like to thank all the panelists for their active participation. I learned a lot. And thank you for your patient listening. Back to Talwar, sir.